Yeah, thank you. The usefulness of neurography is well known to all of you. And I think that if we only had permission to use one technique in our EMG laboratories among evoked potentials and EEG and neurography and all that, I think neurography is one of the strongest candidate. I even prefer that before EMG if we had to choose. It gives us so much information. In this case, about the peripheral part of the nervous system, and mainly that we use it for the detection of polyneuropathy, a common situation among our patients, both the pathophysiology and the degree and the distribution to add to the clinical information. And also all the local neuropathies, localization to the carpal tunnel, to ulnar, uh, to elbow, and radiculopathies, and so on. And the pathophysiology, the type, if it is demyelinating or conduction block or axonal, and the degree, severity. So this is a background why I like neurography very much. And the routine is certainly that we do like this. We place one electrode over the middle of the muscle, and this is called E1. Earlier we called it active, but both electrodes are more or less active. So the active is called E1, and the reference is E2. In the literature, it often says that E2 should be at the tendon part here, and you have many pictures of that. But we have found that if we place it too close here, it will pick up a lot of activity from this muscle. So we prefer to move it out to the most distal phalanx. This is true for hand, median, and ulnar, and it's also true for the tibial tibialis nerve when we studied that. And then we usually stimulate at the given distance. For the median and ulnar, we use 80, and then at the elbow. If we had the ulnar, it was below and above the sulcus ulnaris. I don't go into all the positions of the electrode, you know that already. But the principle about this lecture is which numerical information and which other type of information can we obtain from the signals. Here is the muscle, and here is a distal stimulation and a produced C map. And here is a proximal stimulation and the C map at long distance and the C map at short distance. The conduction velocity is calculated between them, as you know, and we from that get an information about the situation of the myelin, and to some degree also it is dependent on the axonal diameter. But the amplitude at distal stimulation tell us about how many axons have we stimulated and can be activated. What about the neuromuscular transmission? If we have a severe myasthenia, we have a lower amplitude. And also the muscle volume. If we change the muscle volume by moving the muscle, we can get different kinds of amplitude. So, and that is an important thing, but we don't use it clinically, but it is an artifact when we are recording. Short muscles give higher amplitude. And here is the parameters that we measure. We usually do that automatically in the machine. And I think with whichever machine you have, you get the following situation: a small stimulus artifact, baseline, and then the signal, which should start abruptly and then go down to a lower value here. This is the negative part, and what we measure is the amplitude, usually from baseline to peak. Um, the duration is measured usually from start to the first passage of baseline. That is the duration, and sometimes also we measure the area within that segment. And here is a not interesting part of the signal. This is coming from the reference electrode and varies a lot depending on where we have the E2. Some literature measure between the negative and the positive peak, but it is recommended to use it baseline to a peak. Um, Here is an example of situation in conduction block. That means that some signals here do not pass through an area, for example, of a compression or an immune reaction. So when we stimulate distally, we get a good response. When we stimulate proximal to this, only some signals will pass and we get a smaller signal. The conduction velocity here may be completely normal because the impulses that pass here may be quite okay, but if some of them have disappeared, we don't measure from them. So mainly low uh, amplitude, a drop in amplitude. And there are different criteria in the literature. When should we say that we have detected conduction block? And there are different rules for that or suggestions for that. In my laboratory, we have used that the drop in amplitude between the proximal and distal stimulation should be more than 25%. But a reduction in amplitude can also be due to a stretching of the signal. So if we have very long signals like in CIDP, then we may get a, a drop in amplitude between two stimulation points, but there is no real conduction block. So 25% and no temporal dispersion, no stretching of the signal. And with no, we mean less than 15%. For the fibular nerve, that was called peroneal nerve before, the fibular nerve, then we allow a drop of 30% and not more than 30% dispersion. And tibial nerve has a very special situation. Its signal is complicated in the foot, so there we allow 55%. This is about the same as in literature, but it is a little more strict on the arms. Usually also there are a reduced number of F waves. If we have an conduction block in the elbow of 50%, an amplitude drop of 50%, then also theoretically 50% of all F wave should be gone. We cannot have an absolutely normal F wave study if we have a pronounced conduction block. This is just a truth, but it is not a sensitive parameter because it is very difficult to count all the individual F waves. So then we take another type of pathology, namely demyelination. And here we have a local area of a demyelination. We can also have a generalized, but this is an example of a local demyelination. If we stimulate distally, we perhaps get the normal response here if we have a normal part of the nerve. But if we stimulate proximally, then it will be slowing in many of the axons here, and the response will come later than expected. That means low conduction velocity, and also a broader signal. It will be stretched out in time. And here's an example where we have the distal response here in a patient with HMSN1, sarcomatoid tooth. Here we have the distal, and here is the proximal response. And you see here it is the whole response that has moved compared to this one. So it is a general slowing of all the axons in the nerve. If we have a CIDP, it may be that some axons conduct very slowly and others are nearly normal. So then we will get a very dispersed response instead. But here is a homogeneous response. Here it was 35 meters per second, which is slower than expected. There is a slight decrease in amplitude, only 16%. And the demyelination neuropathy is identified in different literature that conduction velocity should be lower than 60% of the mean velocity in the normal material. And in median nerve, for some reason, 38 meters is the dividing point. So if it is lower than 38, then we say, aha, it must be a demyelination here. And if it is a generalized demyelination, then we have distal latency that are prolonged, more than 7 milliseconds. The normal is often around 4. And it can be normal amplitude if all the axons are slower and moving together, and it can be reduced if there is a great dispersion. I shall go back to the previous conduction block here. Why are we interested to measure conduction block? Yes, if we have an autoimmune neuropathy, like in Guillain-Barré, we have conduction block. But if we have a hereditary polyneuropathy or a toxic polyneuropathy, there is no conduction block. So we have to hunt for conduction block, because then we are talking about a situation which is potentially treatable. Then we go to the next type of pathology, and that is the axonal degeneration. If we have a knife cut or a problem here in the nerve, during the first few days, we don't see anything in the distal stimulation. But when Valerian degeneration has occurred after 5 to 7 days, then the axons disappear, and now we stimulate here and we get a low response. And when we stimulate here, we only get response in these axons that are not cut by the knife. So it is a low amplitude similar to the first, and the conduction velocity may be normal if it is depending on statistically what kind of fibers that have survived. So low amplitude is more or less the only thing we see. This is the most common type of polyneuropathy. 85% of our neuropathies contain a dominant factor of axonal degeneration. Here we have axonal neuropathy, reduced motor and sensory amplitudes. Conduction velocity is more or less preserved, more than 40 meters, and distal latency can be normal or slightly prolonged, because we may have only slow fibers remaining, and no conduction block, no drop in amplitude at proximal compared to distal stimulation. And here you see this is the response that is only 0.3 millivolt high. And here's the same response, no decay, normal velocity 48 meters per second. I should say that if we have so low amplitudes as here, 0.3, then we shall perhaps not make so much measurements of the shape of the area, and because it is very difficult to make good statements if the amplitude is below 0.5 millivolt. Now, this looks very simple, namely to differentiate axonal and demyelinating and conduction block, as I told. But in daily life, we have a combination of these situations. And here we have a schematic drawing where we have a normal situation here, and here we have a drop in amplitude, and here we have drop in velocity. So if we only have drop in amplitude, then it is easy, then it's an axonal. And if we only have demyelination with slow velocity, slowing of velocity, then we have demyelination. But often we have something in between. And then we have to judge and see if it is mainly demyelination or axonal. The most likely is it axonal. And then we have to also think of other factors that we don't go into here. And we also always have to look at the degree of a conduction block. Then it is always demyelination and a great chance of an autoimmune situation. We have many parameters that change the result in the neurography. Electrode type and position and muscle length and all this. Temperature, very important. So these are important things to think of, and we don't go into all these details now. But I want to show another thing that is very useful, and that is to make very short steps when we do the conduction velocity. Here we are recording from the adductor digiti minimi, and we are stimulating at 1 centimeter distance. 1, 2, 3, 4, 5, 6, 7, 8, 9. Here we have 4 below and 4 above, and 1 in the sulcus ulnaris. And when we now have here, this is below 40 millimeters below the sulcus, and little higher, 20, 10 sulcus, and then more proximal. And you see a nice, a smooth increase in latency. But if we have a retroepicondylar ulnar lesion, we have below the sulcus, we have this one, and then all of a sudden a time jump. This is easy to see. We measure the time between them and velocity and so on, but it's easiest to see if we just draw a line here, then you see that there is a distinct jump, and we can also use the peak equally well. Both are quite okay. So this is just an slowing. So this is a local demyelination. The amplitude is unchanged. So here's no conduction block. Here we have another situation at the knee, fibular nerve. We do the same thing here with the stepwise increase in stimulation, and then all of a sudden here we have the problem. And here we have a slowing. You see the increase in latency, but also a drop in amplitude. It goes from 5.965 and down to 2.4. 2.4. So this is a drop to about 50% drop. So this is both a demyelination and a conduction block. But there is no axonal degeneration because then the distal amplitude should also be low. And this is good distal amplitude. This is 6 millivolt, which is quite okay. Another thing that is always included in the motor conduction study is the F-wave latency. And here we usually do, in my laboratory, 20 stimuli. And on each trace, there is a combination of many different F-waves. But we say that here we see F-waves only uh, in 17 of the 20 traces, not in this one, not in this one, and not in this one. So the persistence, the frequency of F waves is called that we have 17 out of 20. And the latency is usually measured to the shortest of all the F latencies. And here is the upper normal limit for these patients' height and age. We have normal values for height and age. And you see here, all of the F waves are prolonged. They're later than normal. And that is in a patient with diabetic neuropathy. The F wave latency takes care of the whole nerve up and down from the stimulus via spinal cord and out again. So maybe 2 meters nerve. So it's very sensitive to find the slight changes in conduction velocity. So we suggest that F wave should be measured for every motor study. Only to make a few stimuli is not enough if we want to do some statistics about the frequency. So we do 20, just a number that we have calculated. A short word about the sensory. We can do that antidromic. That means stimulate, for example, in the wrist and record from the finger, or orthodromic, stimulate the finger and record at the wrist. Their velocity is the same and the thinking is the same. And sometimes it's better to do antidromic, sometimes better to do orthodromic. Usually, I'm sure that you do the sural in the antidromic way. You stimulate in the back of the leg and record in the lateral malleolus. You do the radial nerve also antidromically, but the median and ulnar perhaps you do ortho or anti, I don't know. The recording is between the two pads in a fixed bar electrode or two ring electrodes. We usually do not use needles any longer. And here I have one very important information that the nerve is lying here, and we get one signal to the first field pad, and then the same signal little later on the second field pad, two identical signals. And what we record in our amplifier is the difference between these two. And we get this nice signal. So this little signal is actually this minus this. So beginning here is from here, and this peak here is this peak. And you can imagine that if we have a very short inter-electrode distance, if we have rings and place them very close together, we get very small signals. And if we have rings that are very far away, then we start to see the first signal and the second upside down. One minus the other gives this signal. So we have to be very careful with measuring the distance between the rings, and therefore we prefer the fixed bar electrode, because then we always have the same distance. We use one electrode that is 23 millimeters between the two poles, and all our reference values are for 23 millimeters. Otherwise, the thinking of conduction block velocity and uh, amplitude is the same thinking as for motor, and therefore we do not need to discuss that so much. We measure the peak amplitude either from the baseline to peak. And in our case, we have made a special little line here and record between this line and the amplitude. The um, the duration is measured between the first positive peak and the last positive peak. One thing that is so typical for the sensory, but also true, but less important for the motor, is the temperature. Here is a result from a warm hand, the median nerve, and here is when we have a cold hand. With cold hand, we get longer latency, we get larger signals, and more longer duration of the signals. It looks, maybe you think it is a carpal tunnel because the latency is long, but then you also see that the amplitude is increased, and that does not fit to carpal tunnel. Be careful with the temperature. Always measure that before the study to keep a constant and warm back of the hand and back of the foot. We have 29 for foot and 27 centigrade for foot, 29 for hand, 27 for foot. And then finally, it is important to have good reference limits. We have this ordinary formula that the conduction velocity is constant plus a factor times age plus a factor times height. This is a typical, and it is usually possible to insert this in from the literature into the machines and calculate automatically if your value is deviant from the expected value. But remember that age and height are very important, particularly in all situations, also not only in pediatric combination situation. Now I go over to part 2, and that is little about how we use neurography and EMG together and how we combine them. I have a little sketch here with some different conditions just as examples. And I say, shall we use neurography, repetitive nerve stimulation, autonomic testing, EMG, single fiber, other things in this situation? Shall we use both of them in all situations? Or is it enough with EMG sometimes? Is it enough with neurography sometimes? Let us look at only just a few examples as long as we have time. Here I take neurography. You and referring doctor are not interested just to know that the velocity is 51 meter per second or 38 meter per second. You want to get more out on neurography. You want to know the pathophysiology, which we have just talked about, if it is demyelination, axonal conduction, if there are both sensory and motor and autonomic nerves, if it is distal and proximal distribution. Here you see Guillain-Barré, it is usually very much more proximal. If it is CIDP, it is also proximal. If it is Charcot-Marie-Tooth, it's an even distribution. anti-MAG is just a distal distribution, and so on. And then we try to grade the severity of the neuropathy. So that is something that we can get out of neurography. And what about, well, autonomic testing? If the patient has symptoms, we may have a situation where we want to do RR interval heart rate variation or sympathetic skin response. They are not so precise, but they are very good to have. I leave that. And what about EMG in a patient where they ask for a polyneuropathy? Well, it is actually not always necessary to do an EMG. If you see the typical changes in the neurography, then one can say, why should we add EMG here? And if I ask you and you not now answer, I know that you are thinking, well, I want to see how much denervation there is. The problem is that denervation is very difficult to quantitate. Should it be much fibs in one site or many sites with little fibs and temperature and all that makes the quantitation very difficult. But an denervation of severity is more robust to measure as the motor and sensory amplitude. The motor amplitude is well related to the number of surviving motor units. But if we want to do the EMG, then we should look at the long nerves. At least the axonal polyneuropathy is length dependent, so we should do that not in the trapezius and the deltoid muscle, but we should go out to hand and foot muscles or distal leg muscles, the long nerves. If we have a demyelinating neuropathy also, a typical sign is that we do not see any denervation or renervation. Then it is only slowing of conduction, so very little at least of this kind in demyelination compared to axonal. And then maybe we want to see other things. We may have a surprise. Maybe it was not a distal neuropathy at all. Maybe it was one of these distal myopathies and so on. It is sometimes very useful, but I say it is not always necessary. And if we have a diabetic neuropathy, it's good to have the picture at least once in the patient. But when we make follow-up every 3 months or every 6 months, a good neurography can be enough. Guillain-Barré. What about Guillain-Barré? Well, here in neurography, we want to demonstrate acute motor and sensory neuropathy, more motor than sensory. Usually in other neuropathies, it's more sensory than motor. We want to demonstrate conduction block, not necessarily in every nerve, so we had to do it in a few nerves to test and try to assess the type of pathology and distribution. And what about, so it is very important with the neurography, and that is abnormal already from day 1 or day 2. The first things is that we start to see A waves in the neurography. Autonomic testing is also very important in these patients. And what about EMG? Well, in the early phase on day 1, 2, 3, EMG does not give any diagnostic information. Still, we have not got the denervation, and there is no reinnervation, and so on. So it is really only uh, a reduced interference pattern, but it is not diagnostic for Guillain-Barré. Later on, maybe we want to see the axonal involvement and the degree of re-innervation, but that is another thing, but not in the diagnostic phase. And then we have we have other things here, antigangliosides. When we want to differentiate between the axonal type of Guillain-Barré, AMAN and AMSAN, then we have the axonal type. They have a lot of antiganglioside antibodies, and the ordinary Guillain-Barré AIDP, they do not have the antibodies. Then we can take another example, for example, root and plexus. Does neurography help there, or is it EMG? I think EMG is the most important here. We want to see which levels that have been involved, and if it is both the anterior ramus and the posterior ramus. That means arm and leg muscles and paraspinals, which is differentiation to the plexus involvement. So EMG is certainly necessary in different root levels. But what about neurography? Well, if we have a patient with sensory symptoms, reduced sensation in hands or arms, and we have a completely normal distal amplitude, that is very likely to be a root because the distal part, distal to the ganglion, has survived. But if we have patient with sensory symptoms and reduced amplitude, then it's more likely to be more distal. It can be a plexus or it can be in the peripheral nerve. So from this point of view, it is good to have the neurography and compare to the sensory symptoms. We can take another example. So the summary here is that both neurography and EMG together. If we take motor neuron disease, ALS, there, as previously, we always said that the EMG is very important, and that is actually part of the diagnosis also in the different criteria with the denervation, generalized denervation, and the fasciculations and so on. So EMG, we want to confirm a generalized denervation and unstable motor unit potentials and fasciculations. We have the other type, MMN, multifocal motor neuropathy, which is a cousin of CIDP. That is not, but it can simulate ALS. And that has an abnormal nerve conduction study. So this was easy, but now you can say that this denervation can also be due to a neuropathy. It can be an axonal neuropathy and not in motor neuron disease. And therefore, we earlier said that we must go and make neurography to see that we have normal neurography. So exclude axonal neuropathy. So neurography is important. It should be in principle normal, but not always. We may have a slight involvement of the sural nerve, for example. So, but it should not be a very large or clear sensory neuropathy. And when it comes to MMN, then it's another thing. It is conduction block in many nerves, not all of them, and that is very easy to show, and that is important. So we always should hunt for conduction block and also report no conduction block was seen. That means that you know that you have thought of it. We shall just take one example more here. We can take myasthenia, for example. Shall we do neurography? Start with the neurography and start with the EMG and so on? No, it is really not the starting point. The starting point is probably repetitive nerve stimulation. And usually 10, 60 seconds of activation, and to see the decrementing response in proximal muscles. And we look at the differentiation to Lambert-Eaton that has a very pronounced facilitation. But what about other things? What about neurography in a question patient with myasthenia? There is really no primary reason for neurography. Only if things does not fit at all, you say maybe it's not myasthenia, maybe it's something else. But just for the primary typical situation, we don't need that. But repetitive stimulation is good, and then certainly the most sensitive is the single fiber EMG to see the jitter. That has more than 97% sensitivity. So an ordinary EMG, we do not usually do that. If we do EMG, we change filters, the electrodes, and do single fiber instead. No diagnostic information from a completely conventional EMG. So, colleagues, I think the time is out for me. It is more than 40 minutes, and I thank you for listening, and I hope you have heard what I said, and we will see if there are questions, if we have time, or otherwise I just say thank you very much.